Okay, so now for vision assessments, we're going to discuss why OTs do vision assessments. So in occupational therapy, the purpose is to elucidate client factors, visual functions, and functional vision that hinder or support engagement in desired occupations. Also, all neurologically impaired clients should receive OT vision screen to rule out any visual dysfunction that can hinder occupational performance. And as well for older clients whose vision may have been affected by age-related diseases can also affect them in occupational performance, which we can address. So now assessment of vision includes basic eye history. You want to ask them, do they wear glasses? What kind of glasses? Do they wear contacts? Why they wear contacts or why they choose to wear contacts? Have they had any injury to their eye before? Have they had any procedures done to their eyes? How often do they have their eyes checked? Do they currently have cataracts, glaucoma, or anything else? Have they noticed a change in their vision? And if they do say yes, ask them to describe the changes. And also, do they currently feel well? And then you move on to interviews with the client and or family about subjective complaints. Example, they might have difficulty concentrating, double vision, eye strain. Family might notice or might mention that they've been bumping into objects on one side commonly or frequently. And then after you've done the interviews, you screen for visual attention and visual search. You also observe them in functional tasks, and then you can also do formal vision related questionnaires. And now screening the foundations of visual function includes visual acuity, visual fields, and ocular motor control. It's very important to screen these foundational visual functions because clients may not complain of any problems, although they might have visual deficits, and then it can affect their performance. All clients should be screened for refractive errors, which is also corrective glasses, prior to screening foundations of visual functions. So reminding them to go to their eye doctor before to get corrective glasses. And now, a screening for distance visual acuity can be done by OT. So this is just where you patch one of the client's eye first, and then you tell them to read letters off of a chart that is like either 4 meters away, and the client must wear their corrective glasses before. And then you just ask them to name the letters on the chart starting at the top row and then move down. And if they can't read, that's when you adjust the distance. Yes. And then for the next one is screening visual fields. Clients should not wear their glasses as it might obstruct the way of visual targets. So you instruct the client to look at your finger, which you hold between your own eyes, and then you let the client, you'll be moving the target from side, and the client should tell you when they first see the finger moving in their peripheral field or visual field. And then you start your fingers at the 12 o'clock, and then you move it clockwise to the 2, to the 4, to the 6, to the 8, and then to the 10. And then for confrontational testing, it is typically used to screen for gross visual field deficits. It has been found that it is relatively unreliable, therefore it should be used in conjunction with functional observation. And then for saccade screening, client must wear their contacts or glasses, and then the client is seated directly in front of you and facing the examiner. So you hold 2 wands approximately 16 inches from their face, and you separate it approximately 8 inches, and you give no instructions regarding their head movements. You just tell the client, look at the red dot when I say red, look at the green dot when I say green, and then you remind them to wait until you say look. So then you tell the client to look from one target to the other for a total of 10 fixations, 5 round trips. So then you observe the ability to, if they can complete 5 round trips, the accuracy of eye movements. Are they, so you know, are they overshooting or are they undershooting? And then you also note the movement of the head and their body. And then you screen, next is screening for smooth pursuits. The client is seated directly in front of you, facing you. They must wear their contact lenses or glasses. So for the procedure, you give no instructions regarding any head movements. You just tell the client, watch the target and don't take your eyes off of it. You move the target clockwise 2 rotations and then counterclockwise 2 rotations. You're looking to observe for number of rotations the client is able to complete. Are they able to maintain fixation, which is the number of times the client has to refixate, so go back. They lose track and then they go back. And you also notice the movement of their head or body. And this is also just to check if they're compensating. Are they having to move their body to look at the target? So some side notes: when tracking and following objects, the eyes must keep the object of regard in the area of the clearest vision, so fovea. So that in order to track, the fovea is the main one that is working. And then eyes make smooth pursuits in order to maintain continued fixation on the moving target. So an example can be anyone watching an airplane take off, which is you're using your smooth pursuits to track the airplane. So the next screen is for convergence deficits. The client seated directly opposite from the therapist. They must wear their contact lenses or glasses, and their head should be vertically erect. So for the procedures, you slowly move a pin light or target towards the client at an eye level, and then you ask the client to keep their eyes on the light and to report when the light appears to be blurred or when two lights are seen. You note the distance at which this occurs. This is called the break point. And then you observe for a break infusion. When the break infusion occurs, move the target in another inch or so, and then you start to begin to move it away from the client. And then you ask the client to let you know when they can see one light again, and then you also note the distance at which the fusion is reported back again. The break-in fixation normally occurs between 2 to 4 inches of the face, and then the recovery of the fusion or fixation of a single image occurs at between 4 to 6 inches. Clients may not report seeing double or blurry image, and that is because of suppression of vision from one eye. It is why it is important to observe the eyes and note if one eye drifts out or in during convergence and pulls back in or out with fusion. So the next is eye alignment. It is to objectively measure by observation of the light reflected off the corneas with both eyes at the same time. The client should wear their glasses or corrective lenses if they wear it. So you ask the client to gaze at a target about 20 feet away. Then you hold a pen light centered approximately 16 inches away from the client's eye. The reflection should be in the same position in both eyes. And then if there's any discrepancies in positions, you note them. So this picture just shows the centered light where it's both the same. But then you see how on the next picture, one is in the center and one is a little bit down. And the same with that notes a deficit in eye alignment. And now for visual processing deficit screening. Just to note, visual attention and visual search seamlessly coexist together, so screening occurs at the same time and they cannot be separated because visual search is the expression of the client's ability to selectively attend, disengage from, and shift visual attention to find new targets. Good vision search includes the following: initiation of horizontal or vertical pattern, an organized and efficient strategy, symmetrical engagement in the visual search without drifting off, successful identifications of targets, ability to search increasingly complex environments. And then one thing we note for visual processing and hemming and attention is the difficulty with alertness and attention, separation bias, and difficulty with forming a mental representation of a space that includes the involved site. So this is one thing that OTs can assess. And we also want to discern between the possible symptoms of visual field deficits and unilateral neglect. As mentioned before, there are two different types of things, and then I just noted exactly from the chart that was mentioned before, the differences between two. So you want to make sure you know during the assessments that you can distinguish between the two. And this is just some of the assessments you can use for peripheral personal space visual search assessment, and then I'll break it down each by one. So these assessments are commonly given in the form of pen and paper at a desk. And the first one is line bisection. So this, you basically just tell the patient to cut the line in the middle, and then you see if they are dividing the lines in the middle. Some with hemming and attention will not be able to. They can't distinguish where the center of each line is. And then the other one is single letter cancellation. You tell them whenever you see a B, cross it out. So they go in order, or if they cannot, that's when you note a deficit. And then another one is design a copy. So you ask them to just design, you give them an image and then just for them to copy. Some of them with visual field cut will only draw one, or hemming and attention will only draw one side. So you got to distinguish between the two. Visual field deficits, they'll be able to compensate. So they're going to be moving their head more. So you have to note that as well. And lastly is drawing a clock. So you ask them just to draw a normal clock, but some patients with deficits will do abnormal patterns, which include the following examples of some of the abnormal patterns. And then for extrapersonal space visual search assessments, you can use Scanboard, which assesses attention of extrapersonal space when the client is stationary. So you tell the client to point out 10 numbers as wherever they see without any cueing. You record the number, the order of the numbers read. Scanboard tells if the client used an organized sequential search strategy or whether the search was disorganized, random, or abbreviated. Another assessment you can do is visual search of extrapersonal space during ambulation, which can be observed by asking a client to identify features of the environment while walking through. It is recommended to place 1-inch letters or numbers along each side of the hallway at various heights and distances from one another, and then you just ask the client to point out and read each letter or number while they're moving down the hallway. And then for reading assessments, it examines the impact of central loss on particular aspects of reading acuity, size, speed, accuracy, and comprehension. So you visual recognition of words, eye movement control during reading, and the interference of central scotoma are measured by using the Pepper visual skills for reading tests. So you just ask, the clients are required to read out loud unrelated letters and words in rows with varied spacing while examiners record errors and the time to complete. It reveals the reading rate, line mastery, and prevalent errors in reading for the print size in which the test is presented. And then another one you can do is Morgan Low Vision Reading Comprehension Assessment. It uses the close method in which a word is omitted from a sentence and the client is required to provide the missing word after reading it only once. Another reading assessment is the Minnesota Reading Acuity Chart. It is designed to measure the effect of print size on reading speed. Client reads the sentence out loud while the examiner records the time taken to read the sentence. The smallest size print that is read fluently and without errors is the fastest time is called the critical print size. Smallest print size regardless of reading speed is termed reading acuity. Critical print size is used to determine the amount of magnification the client needs in order to read standard print.